Okay, great. Hello, everyone. I hope you can see and hear me. My name's Sally Lewis. I'm the National Clinical Lead for Value-Based Healthcare in Wales, and I'm also a general practitioner in the Welsh Valleys. I've been asked to speak to you today about value-based healthcare, or at least the Welsh take of value-based healthcare, because I think value is a very tricky word, isn't it, and is variably interpreted around the world. So I hope you're all sat there comfortably with your sandwiches. As you can see, I'm on my sofa at home. It's 7 o'clock here in Wales, so I hope the dog doesn't bark in the middle of this, but we'll see how we get on. So, what we're going to cover today is the Welsh view of value-based healthcare and a little bit of history of that, but then get very quickly into how we think we might generate value for patients across an integrated healthcare system, how we can collect and use patient-reported outcomes, and then I've put in a few thoughts about how that relates to health technology assessment, particularly for medical devices, just at the end of the presentation. We should have plenty of time for discussion and questions at the end. So back in 2014, the then Cabinet Secretary for Health in Wales, Mark Drakeford, launched a policy, I guess, called Prudent Healthcare, which I think was borrowed really from parsimonious healthcare in North America, and I think that was in Canada as well, if I'm not mistaken. Somebody can't hear me. Is that the only person that can't hear me? Because my microphone is on. Can I just check that everyone can hear me? Okay, I think everyone can hear me except you, Payal. Anyway, Prudent Healthcare. So Prudent Healthcare was launched by the then Cabinet Secretary Mark Drakeford, and it was really in response, I think, to a growing sense of unease that something was wrong in healthcare, that we were not achieving the outcomes that we expected for our patients, and we were perhaps not directing our resource in the best way possible. And it was really a daughter of parsimonious healthcare, but parsimony doesn't really work as a word in Wales, so we had to change the language around that. And as you can see from the icon, it was really around trying to promote a new relationship with patients where there was increased responsibility for health and working towards a shared understanding of medicine and truly shared decision making towards better outcomes. We were also very interested in promoting equity across the system and caring for those with greatest health needs first, and avoiding harm through over-treatment and over-diagnosis, and of course tackling unwarranted variation. And what we found with these principles was that there was nothing really to disagree with these principles, but we found them to be quite abstract and conceptual. And we didn't have any data, so we didn't have any delivery mechanism for prudent healthcare, and it was that really that led us into thinking about value-based healthcare really as a delivery mechanism for prudent healthcare. And of course this was all very much in line with other approaches and thought pieces that started to come out afterwards, like realistic medicine in Scotland, slow medicine in Italy has been going for a long while. Also drew in elements of choosing wisely and other things like that. So there's this real movement around the world towards this type of approach. So then we began to look at value-based healthcare in Wales, and as you will know, the major theory from Michael Porter in Harvard Business School talks about value as a function of outcomes over costs when we're thinking about outcomes that matter to patients. So have you improved my pain? Have you improved my function? Rather than a clinical indicator like a blood test in diabetes, for example. So it's really coming at it from a patient's perspective. And that was something that resonated with me, certainly. But of course, in an integrated healthcare system, particularly one that's publicly funded, we're interested in how we allocate resources in a fair and equitable way across the population to achieve population value, and also how we allocate resources between different interventions for a particular subpopulation, let's say a population of patients with COPD or diabetes. So in the Welsh context, it's not about competition. On the contrary, it's really about collaborating to achieve best outcomes across the whole system and using the data to help us understand how best to allocate resource. So that's quite different from the US view of value, I think, in how the view that competition will somehow improve value for patients. That's not how we see it in Wales. So how might we generate value across the system of care? Well, I think that too often we look at value or look at patient care through the lens of a service rather than from the patient's perspective, looking at everything they might need across that system of care. So to generate maximum value across the system of care, we somehow have to find the sweet spot between these 5 elements, moving from prevention, early accurate diagnosis, optimising intervention, and on then into supportive and end-of-life care if we're looking at a chronic disease. So maximising value across a continuum like that often means making sure that we do the basics really, really well. And actually, that's often not what we do in the healthcare system, is it? We quite often invest very large sums of money for very expensive interventions which have marginal gain, and we do that at the expense of other things which are much less costly but actually have much greater gains for patients. And I've got an example of that to show you in a moment. So there are patient ways of increasing value, and there are healthcare factors. So from a patient perspective, of course, we would want to raise health literacy and support healthy behaviours towards preventing disease, because that's a very high value intervention in terms of the outcomes you get for the resource put in. But we'd also want to support that shared understanding of medicine that I mentioned earlier, so that we want people to make choices that make sense for them in their context, not just what an evidence-based guideline might say. And that's really important, particularly in oncology, for example, where there may be significant trade-offs between the outcomes that may come from choosing a treatment such as a palliative chemotherapy. The trade-offs between length of life and quality of life can be quite difficult. Healthcare factors, of course, we want to decrease unwarranted variation. We want optimum positioning of drugs and devices. So we want to make sure that when we prescribe or when we are using a particular device, that we are choosing the patients who are going to benefit the most from those interventions, and we are deprescribing where the medication ceases to have a benefit. Deprescribing, particularly in the elderly, is extremely important if we're to avoid harm, of course. Moving from an ideal population to a real population. So, as we all know, randomized controlled trials being the gold standard for evidence generation in pharmaceutical trials, often the selection criteria will exclude the very patients that we will sometimes extrapolate that evidence to. And nowhere is that more true than in general practice where I work, and you're trying to navigate a whole series of single disease guidelines, for example, for an individual patient. So really sort of personalising care. So when I use the term personalised medicine, that's what I'm talking about, not genomics, completely different thing altogether. Focusing on meeting true need, and I'll show you in a moment some data which will show how we can use PROM data to look at a really granular needs assessment for a population. And And of course, how we allocate resource very much dictates whether we're going to get value for our population. I have to say it's very weird presenting into the ether here, so I hope you can all hear me now. So I want to extrapolate from the previous slide that generic pathway into an example of how we might improve population value in heart failure. So once we get past the prevention element and preventing cardiovascular risk factors, we want to get into early accurate diagnosis. Now, extracting the maximum value out of the diagnostic pathway in heart failure means that we need to look at not just access to echocardiography, but whether we're screening out appropriate numbers of patients using pro-BNP testing. Now, recently I was involved in a health technology appraisal in Wales for handheld echocardiography in the community. And on the face of it, it seemed like a no-brainer to increase access very quickly to a diagnostic test for heart failure to speed people into treatment. But actually, what the evidence didn't tell us what the impact on the pathway was going to be. So actually it turned out to be, at the moment anyway, in the absence of that evidence, a less valuable intervention, because everybody that had a handheld echo still needed to have a gold standard echocardiogram to ensure an accurate diagnosis. So although on the face of it, handheld echocardiography was pretty sensitive and specific, and there was sort of low interoperator variability between GPs and cardiologists at this moment in time. It was not a high value intervention because it couldn't significantly change the pathway for diagnosis, and in fact added another step and added costs into that pathway. So we need to be careful that diagnostics are not a vanity, that they actually do add value for patients. Then, of course, in heart failure, optimizing medication is really important. We often assume that is done in a timely and complete fashion, but often isn't. So thinking about how we use our workforce to achieve these tasks is extremely important. The GP may not be the best person to do the job. And then on to devices. I've been at industry presentations where it's suggested that everybody with heart failure should have telemetry, and we should be extending the use of implantable resynchronization devices to wider groups of people. And actually, if you look at an atlas of variation in cardiology in Wales, you'll see that your likelihood of getting an implantable device is directly related to your proximity to a tertiary centre, not any other indicator. So there's something weird going on with devices there. We need to make sure when we're using devices that they're going to be benefiting the patients that we're putting them into, and not everybody with heart failure will benefit from those devices. So if you have a patient who has quite severe heart failure, and your pathway is telling you should be offering, let's say, an implantable defibrillator, it's worth looking at the patient in the round to see if that makes sense for that patient, because I've seen these devices put into people with dementia who actually really didn't want that intervention. They would rather have had a palliative approach to their heart failure, not an aggressive ongoing therapy. So making sure that we are really careful with how we use interventions and knowing when to stop is equally important, and getting all of those basics right along the pathway. But again, I'll explain in a moment how I think patient-reported outcome measurement can help us make those decisions and can indeed act as triggers for those sometimes difficult conversations. So a lot of this was meant to be solved by evidence-based medicine, of course, and evidence-based medicine brought us on huge leaps and bounds in how we thought about medical care and how we introduced new interventions into medicine. But unfortunately, it hasn't solved all of these problems, perhaps in the way that it was originally intended. And I'm not going to talk about how evidence generation can be manipulated or corrupted today. But what I would suggest to you is the missing bit from the original definition of evidence-based medicine is this second statement. The patient brings to the encounter his or her own personal preferences and unique concerns, expectations, and values. The proliferation of evidence-based guidelines, protocols, and algorithms over the last 20 years has been extraordinary and has created even a tyranny of guidelines, actually, when you're trying to navigate multiple single disease guidelines as a patient with your clinician. And they have created almost unseen rules. So it's quite hard to deviate from those guidelines that are written down. And that has led, in some cases, I think, to a sausage machine of care, or quite a mechanistic view of care, really, almost tick box care, which is not the care that we would seek for ourselves or our families, I'd suggest. So evidence-based medicine has been, to some extent, a double-edged sword then, and what we need to do is bring back the patient element to that and have much more nuanced conversations about how we are using this evidence in the context of individuals. So here's an example of how evidence is applied in practice. This is quite a common example of value in chronic obstructive pulmonary disease, and is an example that I tested out in my old health board when I was assistant medical director there. So the highest value interventions, the highest value evidence-based interventions for a population with COPD are smoking and flu immunisations and pulmonary rehabilitation, in the sense of the outcomes that we get for the money that we put in, so cost per quality. So you would expect that we would maximise our investment in those things in relation to what we're spending on inhaler therapy. But actually, what we found, and this is not unique to Wales, this is quite a universal finding, I think, is that we found that there was significant underinvestment and inequity across the county in investment in pulmonary rehabilitation in particular, whilst we were spending vast amounts of money on triple therapy inhalers in COPD, which were very expensive and not probably giving us hugely better outcomes. Certainly from the data that we had and from the cost variation data, we were spending more on inhalers in COPD, not just compared to other places in Wales, but actually compared to the whole of the UK. So we came together as a group of clinicians, patients, managers and financial managers, pharmacists, to try and rationalise that and rebalance the expenditure. So it wasn't about using the cheapest inhaler even, it was about having a rational, thoughtful scheme for how, when and what inhalers we would use, and always having that agreement with the financial managers at the beginning that we were going to reinvest in pulmonary rehabilitation to rebalance that value across the system for a population of COPD patients. And we did that. And the postscript to that was that there were 5 models of pulmonary rehabilitation across the county, and they then did a comparative assessment of costs and outcomes between their different models to see which was the highest value model for patients. So that was quite a successful way to engage clinicians activity which not only saves money, and we're always being asked to do that, but to reinvest for high value for patients. But this sort of scenario is really common across many disease areas. So we see this a lot in diabetes as well, where we are almost certainly not optimally prescribing, for example, in type 2 diabetes, and yet neglecting really important things like investment in podiatry for good foot care and so on. So one of the striking things about value, and where I do agree with Michael Porter, is that we need to measure outcomes, and particularly patient-reported outcomes. And the consequences of not knowing our outcomes lead us to make wrong decisions all of the time. And I love this quote from Voltaire. I use it all of the time. Doctors pour drugs of which they know little to cure diseases of which they know less into patients of whom they know nothing. Isn't that a fantastic quote? It's still true. So even with evidence-based medicine, hopefully we know a little bit more about the drugs and a little bit more about the diseases than 300 years ago, but we still don't know enough about our patients. And we need to start to try and tackle that. So we don't know real-world clinical effectiveness. So the trials are telling us about efficacy, but what's happening afterwards when we start to use these drugs and devices in the real world, and we know that sometimes pans out quite differently, particularly when we're considering the effects of multimorbidity, patient preference and context. It's really difficult to decide what is bad and warranted variation when we don't have any data to back that up. So looking at clinical variation but with outcome data to back that up means that you're going to have a much better conversation with your clinical colleagues. The holy grail, I think, has to be to build up enough information that we can start to reflect back to patients what their likely outcome is going to be for the decision that they have made based on their characteristics, rather than well, I don't know, but you know, the paper said X, but you're not really like that population that they measured. So we need much more information to help people make decisions about their treatment. And the other thing about outcomes, the other thing about not knowing what has happened to your patients, is that it drives follow-up. And I know that because I do it myself. We worry about patients, and so we bring them back. And actually, as we grow an increasingly large population who are chronically unwell, often with multiple conditions, we do not have enough money, staff or buildings to keep bringing people back to see them sequentially in the sort of old-fashioned traditional way. We need to let go, we need to be less paternalistic, and we need to start really helping people manage their conditions themselves. Patient-reported outcome data can really help us to do that by allowing a remote communication between patient and clinician. And of course, that releases capacity in the system so that we can be much more responsive. I think that's high-value care. So, hopefully I've managed to tell you a little bit about what value means to us in Wales and how we're approaching it. So now I'm going to talk to you a little bit about what we've learned about collecting and using patient-reported outcomes. So the first thing we learn about it is that essentially collecting a patient-reported outcome is not primarily about data capture. It is about enhancing communication with a patient, preferably electronically in this case. And once you've enhanced that communication, you facilitate data capture as a natural byproduct of that, because it also enables other tasks to be completed by the patient with their clinician. And it starts to normalise a new way of working together. And that's what allows large-scale semi-automated collection of patient-reported outcomes. If you don't do that, you can't do it at scale reliably and expect to get high response rates. It has to be really embedded in direct care and be meaningful for patients and clinicians alike. So therefore, how we visualize the data, both from a patient view and a clinician view, and have that accessible for people, preferably in real time, is really, really important too. So it's really, really important to embed this in direct care. I can't emphasize that enough. So what else might we do? Well, I never expected this when I started to look at collecting patient-reported outcomes, but I went down a real digital rabbit hole, if you like, because once you realise you can enhance electronic communication with patients, there are so many other possibilities for generating new models of care, flexible access to healthcare providers by, for example, allowing people the ability to book and cancel their appointments, to have access to and share parts of their medical record with their family and with other clinicians, access to test results, clinical advice, and so on, even being able to link to wearables, if that makes sense, and supporting people with managing their chronic disease through self-management resources and so on. So there are loads of digital tools which can be useful as well for different groups of patients. So if you start to enhance this electronic communication with patients in lots of ways, you will then make structured communication using a patient-reported outcome tool an absolutely normal thing to do, and you'll get very, very high response rates. And in the Honorary and Bevan Health Board, where they started doing this first of all, using that technique, they've got their remote response rates up to about 70% or more, which is, you know, much higher than you would normally expect for a remote collection of patient-reported outcomes. And I'm sure that that will improve as we embed this new way of working over time. But of course, this requires massive behavioural change. It's not the technology that's the problem. It's our ingrained way of delivering healthcare. And nowhere is this more true than the outpatient model. And everybody needs to change. This requires a massive change in clinical behaviour, patient behaviour, managerial behaviour, and informatics behaviour as well. We have to reimagine ourselves together. And that is a slow process. So this is not something that changes the system overnight. It's attritional warfare. Basically, it has to take years to embed this, but you can start to see some significant progress after about 2 years once you start getting into this program of work. So how might we use the patient-reported outcomes? Well, there are obviously real differences between how we might use this data in a chronic non-malignant disease like heart failure compared to episodes of care, which I guess is more traditional PROM use, like a cataract pathway or a joint replacement pathway. And actually, I think cancer has nuances as well that are different from heart failure. So there are different ways that we might use this. And outcome, I think, is sometimes a misnomer in this context, because it's more, we're using the data often as a status rather than an end outcome. So the outcome is a milestone or an endpoint or a consequence which matters to a person at a given point in time. It's not always the end point. So at an individual level, patient-reported outcomes are fantastically useful as a symptom tracker, enhancing that communication, as I said earlier, between healthcare provider and patient. Supporting shared decision-making, we've already mentioned, and triggers for key conversations. So, for example, our heart failure nurses are interested in PROMs in heart failure. As you start to see a trajectory downwards, this can be helpful in opening up a conversation around advanced care planning and palliative care, for example. Some of these conversations are difficult to broach, and we know that we're not as good at them in non-malignant disease compared with cancer. So having this slightly more objective communication can offer a way into those conversations, which again then can significantly improve outcomes for patients. And then when we aggregate the data up, much is made about improving outcomes through comparing. I think it's interesting to compare outcomes, but I'm not. I think it is quite difficult to make judgments about why outcomes are different very often, particularly in a condition. Again, I'm going to use the example of heart failure, where differences in patient-reported outcomes can indicate patient choice, can indicate, different stage of disease. It's not that straightforward. So I think we need to be very, very careful about that, and certainly without linkage, but we'll come back to linked data in a moment. Identifying unmet need, and I've got an example to show you of that in a moment. We've mentioned the flexible approach to caseloads, so many of our clinicians working with inflammatory bowel disease patients are now using this as a remote communication, so that the patient, if they're stable, doesn't need to come up to the hospital. They can get on with their lives and just have that remote communication. Yeah, I'm fine, treatment's working, and then access their healthcare professional when they need to, not in a regimented way as they would previously have done. And we've mentioned already unwarranted variation in real world evidence. So I've got some examples for you now. This is unlinked aggregated PROM data from Wales, which I've just done to illustrate a couple of things for you. So this is using the Cancers Cardiomyopathy questionnaire, and I'd like you to look at the bar chart at the bottom of the slide, please, first of all. Now, two of the questions on the Cancers questionnaire ask patients how many times in the last fortnight have they reported swelling in the morning or reported sleeping sitting up in bed. And there is a 6-point scale. If you score 6, then you are very stable and you've had no episodes of this in the last fortnight. If you score 1, you've had both of these things every single day. So when you aggregate the data up with these records, you find that most patients are stable over that 2-week period. So about 2/3 of patients are stable, no symptoms at all, very, very well controlled heart failure. But you'll see that a smaller but significant percentage of patients fall into that severe bracket. So that means that every night they're sleeping sitting up in bed, and every day they have swelling. These two together are a really good indicator of severity of heart failure and are basically telling us that these people are at risk of decompensation of their heart failure and going into acute heart failure and hospital admission every single day of the week. So if you're planning services for your heart failure population in a region, this is really useful information, is it not? Because the model that we tend to adopt is a one-size-fits-all model to look after heart failure patients without necessarily considering the slightly different needs of groups within that whole cohort. So what this says to me is, well, how would we rescue people differently in the community that fall into that severe category? And do they need palliative support? Do they want to go to hospital if they decompensate? How are we addressing their wishes, and how are we getting the best outcome for them given the severity of their disease? So in terms of planning services to support patient care, I think this is incredibly powerful. It's also amazing how many people are triggering on a depression questionnaire with physical ill health. So this we have consistently high triggers for depression and anxiety in people with chronic disease in Wales, and I'm sure that's true across the world. So what does that mean for outcomes? How might we address that? This slide is us playing with data visualization using a radar plot using 3 individual patients The stable patient is in the blue. We have a sort of moderately severe patient in the orange, and the severe patient is in the centre there. Where this is useful, I think, is if you keep your eyes on the blue line for the moment. If you are a heart failure nurse specialist working with a patient who has stable heart failure like this, who is mostly absolutely fine, little bit of physical limitation, little bit of social limitation. If you then look at this PROM at the next visit, you can pick up subtle changes in the symptomatology that's really easy to see in one single view. And that's very, very useful because it's quite difficult for patients to identify sometimes these subtle changes or to remember what they were like last time, because they become habituated to symptom change when they've had them for a little while. So it's really quite useful in helping to manage symptoms and just noticing when things are just going off a little bit. So very, very useful in tracking direct care, and obviously from a patient self-management point of view, very useful as well. We still have a lot of work to do on data visualization. I had no idea what an important topic it is, but particularly when there's a lot of data, there's a real danger that we could bombard patients and clinicians with too much information and not see the wood for the trees. So lots of work going on data visualization too. Here's another example, slightly more traditional. This is mapping the Oxford knee score and improvements in Oxford knee score after total knee replacement by brand of prosthesis. And so what we see here is that most of them are sort of clustered together in that funnel plot there, but we've got a real outlier here where the patients were not doing as well. So what does that mean? You know, it starts to throw up some interesting questions. The final example on data visualization that I wanted to show you was just a screenshot of the Power BI dashboards that we're creating. So for each outcome data set, whether that is lung cancer, you know, a tumour site in cancer, or a chronic disease like heart failure, or an aspiration actually for not just a single condition, but for, let's say, a frail elderly population, we will bring outcome and patient-reported outcome data together in an interactive data dashboard on Power BI so that clinicians and healthcare teams generally can navigate the data and be able to access it readily. One of the problems we've had, as I'm sure you've also had in Canada, is that historically we have tended to feed our outcome data, our clinical audit data, out into registries, and then we don't get it back until we receive a report maybe 18 months later. So we are keen to move away from that approach so that we collect our own data, hold it so that we can analyse it ourselves and use it ourselves, and then feed the registries afterwards, which is a big task, of course. So how are we doing that? Well, we have a policy statement of intent that we need a much more joined up approach to data to get better flow of data and linkage of data. And so considerable investment is now going into the establishment of a national data resource, which will allow that large scale information to be shared safely and securely within NHS Wales. So that will include all hospital data, all primary care data, PROM data from patients, diagnostic data from radiology and pathology testing, structured clinical data from the electronic patient records, you name it, everything will go in there. There is a lot to do to structure that data and obviously improve the quality of it as well. At the moment, I think of it as a data soup, like a minestrone with bits floating around in it. And not being a technical person, I see the aspiration as being more like a lasagna, where you can, you know where stuff is and it's all in a layer and you can access it, link it, and then analyze it. But I think as this develops, it'll be an incredibly powerful resource for us. So just a couple of slides to finish up on before we get into questions. I was over in Cologne at HTAI earlier in the year, and we were talking about value-based healthcare in the context of medical devices, where obviously we're mindful of improving safety, improving outcomes, value, and reducing unwarranted variation in medical devices, because I don't think I'd appreciated actually how little data there often is when medical devices come to market. So it seemed to me that the question was, well, how do we ensure that we're adopting novel products that show promise and may be high value, but how do we support their introduction by being clear about what data we need to collect to prove that they are of high value? So I refer you back to the earlier example about handheld echocardiography. You know, could it replace gold standard echo in a pathway in certain groups of patients, and therefore be really high value for those patients in terms of their speed of diagnosis and not needing to go to the hospital and so on. So I think that's really, really important. But as is this really big problem, which I've seen a lot, which is potential overuse or suboptimal positioning of a product that is cost effective when it's used properly and is of high value when it's used properly, but when used out of context, it's of lower value. So the telemetry in heart failure and devices in heart failure is the example I would use for that. You know, how do we get optimum use of devices, and how can we use outcome data tracking to support that? And the replacement products, I suppose, is in theory more straightforward in that we're just replacing a device that's going to give us the same outcomes but is of lower cost. So it should be more straightforward if only clinicians like me didn't have preferences as well. So in terms of devices and value more generally, I suppose, is that the tracking of condition-specific outcomes and global quality of life post-adoption, or even just embedded in the management of patients day-to-day, is an incredibly rich and valuable undertaking. From direct care through to how we might link and use bigger data sets. But the thing to really get right is outcome use and patient-reported outcome use in direct care. Obviously, quality generation tends to be from EQ5D at the moment. Is there a way that we can start to use those condition-specific tools to augment that quality generation in a really meaningful way? So either by new techniques of quality generation from the condition-specific tools, or if not that, then how? You know, how can we use this data if we're not going to generate qualities from it? Give consideration to the total impact on the care pathway of the intervention and the feasibility of adoption in a local context. So that's back to the handheld echo example again. And differences in approach between diagnostic and treatment devices. Obviously, how we look at value for treatment devices and diagnostic devices will be quite different, particularly with respect to PROMs. So that is the end of the presentation. So we've got plenty of time for questions. We've got a good 15 minutes for questions now. So I have a question from Chris already. He's got in there early. So Chris's question is, Have we any evidence on the impact of PROMs on unwarranted variability in care? Thanks. Oh, it's come up on the screen now, so you can all see it. That's great. On the impact of PROMs on unwarranted variability in care. Yes. In cataract, that's the one that comes to mind immediately. What we have seen is a small but significant percentage of patients having cataract surgery who have had poor outcomes. And the poor outcomes that they have had have been with their visual acuity and their visual functioning. They've actually been worse on both, which really surprised me in the absence of any major operation complications. But there was a clear correlation between that poor outcome and the patient's visual status when they had the operation. So they tended to have a much less severe cataract, and we don't know the reason, but possibly high expectations of what they think cataract surgery is going to do for them. The ophthalmologists were having variable difficulty in counselling patients because they sort of knew this, but they didn't have the data to back it up, to reflect back to patients to say, do you know what, this is your likely outcome if you have it now. Why don't we pause and see what happens over a longer period of time? And so what we're now starting to see is the clinicians feeling confident to use this information to reflect back to patients around decision making, around timing of surgery, I guess. The next stage in cataract, I think, is to really understand the relationship between doing the first eye and the second eye. So you'll know that in England, they recently made what in my view is a terrible decision, which was to talk about rationing patients to only having one cataract done, which actually often makes visual functioning worse. So I think in terms of outcomes and value, the bigger question is what is the optimum time between first and second eye? So that just gives you a flavour in planned care of how it can start to reduce clinician variability in terms of patient selection. There are other examples emerging in how chronic diseases are managed as well, which I could go into later if we've got time. I've got some more questions coming in. So just on another example of unwarranted variability. Unwarranted variability in follow-up is a really, really big problem because it's blows the capacity in the outpatients, means patients have to wait ages. The system is paying a premium for catching up with waiting lists, that kind of thing. Using the PROMs to tackle that issue is starting to make inroads on variability in caseload or sort of starting to reduce the really massive caseloads and waiting lists that are building up. So that'd be another example I would give. Yes, I can say that the presentation is definitely being recorded because I can see a little record icon. So I'm very happy for it to be shared. So Chris has asked me another one, which is, I missed that one. Let's see if I can find it again. Have we looked at optimizing follow-up intervals and or follow-up decision rules using PROMs? Yes, very much work in progress. We think it's particularly useful in chronic conditions like inflammatory bowel disease, inflammatory arthritis, where you have very motivated populations, often working, often have very busy lives, and they are very invested in changing the model of care to this way of working with their clinician. But I think it's got much wider potential. We're really just scratching the surface at the moment. Yes, I guess. Yes. Were you thinking of anything in particular, Chris? I hope you could all hear me, by the way. It's extremely weird presenting into thin air. How do I decide when to proceed with such a program or not? What amount of evidence is required to determine you should continue and it is sustainable? Can I just clarify the question there? Do you mean a program of PROMs collection across multiple conditions? So while I'm waiting for clarity on, okay, yes. It's very much feeling your way, and each project within the overall program is very different because the needs of the patients will be different, the clinical teams will run differently. So this is it's a big change management program, this. Some things fail, and I think we tend, certainly at the beginning, we would tend to go where we had enthusiasts and where they were very clear about what they wanted to do, why they wanted to do it, and those tended to be the more successful projects in the beginning. Now there's very much more momentum around this, and I think people are getting confident that they will have the tools to support them doing this. My main concern at the moment is that as we gather this data, that erroneous conclusions will be drawn from the data. So I think we really have to guard against that. Sustainability comes from building this into direct care and making it business as usual, I think. So going back to that slide on patient-facing applications and thinking about that digital rabbit hole and how we use digital tools more widely to transform care and put PROMs into that. I've got the follow-up question from, I hope that answered your question, University of Calgary, and I'll go back to Chris because, oh yes, the family and care, yeah. So we, funnily enough, I was talking about that today. We have something called the FROM, the Family Related Outcome Measure. And we're keen to test that. There are some information governance issues with it, in that obviously you have to be careful how you administer that. But I think that is highly relevant, isn't it, in terms of assessing the wider value of an intervention, the wider impact of care. Yeah, and there is some of my colleagues using patient-reported outcomes in dementia care are using a questionnaire which assesses carer burden, recognising that the impact on a carer in particular in certain circumstances is quite significant as well, and actually has an impact on their health outcomes. So absolutely, that's the from is more problematic to deploy, but we will get there. And I have a colleague, Professor Hamish Lang at Swansea University, who's looking at that at the moment. Yeah, yeah. So patients and I suppose patients and their families, and I've seen that too. And I think patients and their families will always, there will always be times when they make decisions which we maybe wouldn't make for ourselves, and that perhaps we don't really understand. I guess our duty is to reflect the likely impact of that decision back to them. And I think that if we have this data, this patient-reported data, so it's not us telling, it's, I would hope, and I hope I don't sort of see this through rose-tinted spectacles, but I hope that it will help us to have that conversation a little better. But nothing will be perfect for sure. It's a problem, and I've also experienced that. So one can imagine hospital, yeah, yes, absolutely. And the other thing about Caribbean is that we wonder if we can start to spot signs that the social situation at home is going to break down imminently, and is there something we can do? Can we be a bit more proactive in supporting that family to find a solution before they reach crisis? I don't know, but it would be interesting to see if we could do that. Thanks very much for having me. And please feel free to get in touch if you have any questions that you want to email me or get in touch. We can Skype, whatever you'd like to do. Thank you very much for listening.